I was starving last night. I was so super bad.
Yeah, it's working.
Because those are more dog.
I had ice cream.
Wait, is this the yeah, that's I have a like.
How's everybody doing? You're doing pretty good. Let me tell you what I did last night, because this is like real life cardiology. I'm glad you didn't panic on me, Tim, because I was in the emergency room until 3:30 a.m.
Oh my God.
So this is the cat dragged in version of me. I'm actually doing fine. If I sleep 4 hours, I can be fine.
Oh my God.
I'm okay.
If you're going to do emergency medicine, that will be your norm.
It is. And what's interesting is my mother called me yesterday afternoon late, and she just was having some symptoms, lightheaded, dizzy, couldn't get up, felt like she was going to faint. I thought, okay, we got to go look at you. So I went over there. She didn't look that good, but I didn't have a blood pressure cuff. I had the staff check the blood pressure, a little bit high, but which was kind of odd to me because it was. But checking her pulse, she was in AFib, and there was no two ways about it. I mean, it was racing along pretty good. So I took her to the emergency room up in Edmond, and one of your classmates ahead of you, Alex Irvin, was in the ER. She's doing her preceptorship. And I said, well, we're going to go from SP to RP, real patients. So let me see what you can do down here. So when she got in there, she was she actually had a UTI, asymptomatic. She had nothing, and this has happened before. Asymptomatic UTI. She started feeling kind of crummy, probably early yesterday, and she didn't call and tell me. I said, you need to call me about stuff like this, so we figured it out. So she didn't really consume a lot, so she got dehydrated. And then when she got dehydrated, she went into sinus tachycardia. She was tacking, when they finally got her, when I got her to the emergency room, she was out of AFib again, but she was operating at about 120 to 140, and we figured that the excessive sympathetic stimulation from that dehydration state probably set her up for some AFib paroxysmally. So we checked her out. Electrolytes were fine, everything else was okay. Got her treated for the UTI, and I got her back into assisted living at 3:30 a.m. And I went home, and my dogs thought it was like, you're coming home for the first time, so they were all like, oh Lord, I'll see you to chill with me a little bit. So I got up about 8:15 and kind of got myself ready to go. So that's my story for so far. But anyway, it happens. Your classmate did fine. I told her I would be glad to recommend her for graduation. And we can go from there. Oh goodness, well let me go ahead and get started. I've sent you two handouts, or posted two things. One was a copy of the handout, and one was really a slide set that is very much a lot of the same content. I'm going to probably use the slide thing to kind of key off of it. There's a lot of content here. I've got you for 4 hours, so we'll try to work our way through it. And I've got it set up to where I've actually got some cases and little scenarios to look at later in the afternoon, so we can kind of walk through what would you think about, how would you do some of this stuff just to apply some of these guidelines. I have written you out objectives. They're pretty comprehensive if you look at them. They also are application oriented, so it's not only what you have to know, it's what you have to do with this content. So we're going to go ahead and get into it, and we'll see how things go. As you all know, hypertension is a huge issue in this state and really in this country. And it is foundationally one of the risk factors you've already probably dealt with as you kind of talk about different cardiovascular conditions. So let's kind of go back to home base and actually just kind of look at it a little bit, okay? Are y'all doing okay? I mean, y'all had EKG this morning. Y'all look like y'all know worse for the wear. So as y'all work your way through it. Okay. Let's see here. Okay, their guidelines are very important in hypertension. You're going to hear about guidelines wherever you go. And I think the biggest thing you need to know is that there's a lot of controversy about guidelines for managing hypertension. I am going to teach you out of the JNC 8, which is 8th report of the Joint National Commission, or Joint National Committee. That's a group of a lot of different healthcare providers from a lot of different disciplines, and they have been releasing guidelines since 1976. I joined into this thing when they were at JNC 3, 3, I guess, and I've aged enough that we're now up to 8. And 8 came out in 2013. So that's a foundation. When you look at a lot of the other data that I'll present to you, everybody keys definitions off of JNC 8. But let me give you some more controversy about guidelines. Everybody does not agree. In fact, if you watch the news for health-related issues, and you'll probably start noticing more stuff. The more you know, the more you notice in the news. You know, it's like the more informed I get about a topic, the more I start understanding what the discussion is out in the street. But there were new guidelines released, different guidelines released in November of 2017. And I think I put the PDF on D2L. Please, did I do that?
Mm-hmm. Yes. Okay,
thank you. I had a little moment of hesitation, my little brain wasn't fired right. But the American Heart Association and the American College of Cardiology have been in a fight with the JNC 8 for a while about what they want the guidelines to be. They actually advocate treating at lower levels. This has been the issue all along, is what level is hypertension by definition to the point where you need to initiate treatment of some sort. So they advocated initiating treatment with lifestyle medications at greater than or equal to 130 over greater than or equal to 80. So that's a little bit lower definition than what the JNC does right now, which is greater than or equal to 140 over 90. So you've got those two definitions. There was a hullabaloo when it came out. Does anybody remember the hullabaloo? Does anybody remember the hullabaloo that happened in the fall? Okay, Professor Roark does. What happened is when they changed the definition, they actually changed the number of people who would be diagnosed with hypertension, and it becomes a public health issue. You know, are you treating everybody? Are you doing the right thing? So by their definition, the guidelines released in November, 46% of Americans have high blood pressure compared to 32% by the JNC 8 guidelines. But most of the new hypertensives were people who were less than 45 years of age, so really it's your generation. And Professor Roark became one of those people, fell into those guidelines. I don't want to get into all of the ins and outs of this right now because it really will kind of, it'll blow your mind a little bit. But let me just give you just an overview. I'm not going to ask you to remember this. American Academy of Family Physicians came out against the new guidelines, so the primary care providers have fought against it because they feel like it will increase drug therapy and use in a wide range of people, and that some of those people actually are at risk for being treated. There's a lot of issues about being treated, particularly people who are older. Older people treated to lower levels increases the risk for what? Just low blood pressure, hypotension would be a risk. What's the risk if you get low blood pressure and you're older?
Falls.
You fall. What happens if you fall?
Hip.
Break a hip, break a bone. What happens if you break a bone? Your risk for mortality is fairly high depending on other circumstances about your condition. So family medicine physicians didn't want this carte blanche statement that said treat to this level. They wanted to have the ability to individualize based on other risk factors. Another element that plays into this is that how low is low? This has been a question since I've been looking at hypertension. How low do you treat somebody's blood pressure? What can happen in a person if you treat their blood pressure too low? I mean, cardiovascular-wise. Can you treat somebody so low you could have a stroke? You could treat somebody so low that you could actually have an infarct. Have y'all had, the CAD has not happened yet? But if your coronary artery perfusion is already compromised by blockages and there's some collateralization, the issue that's always come up in these studies is if you lower the blood pressure really, really low, do you create some morbidity and cardiovascular mortality that you wouldn't have because you got it so low that you change perfusion pressures in parts of the myocardium that are already at risk? Told you I didn't want to go this far. so the issue is, how low, you know, when do you start treatment and what should that treatment be and how low do you go? You will go into places where they will fight about this. One reason the family medicine physicians did not want these new guidelines is that in the age of reimbursement and pay for quality of care, the bean counters who are not healthcare providers just start looking at your patient population and they will pay you if you have everybody at the level that they say is it, based on a hard, cold definition. And they don't really allow a lot of flexibility around that based on a practitioner's views of other risks that a person might be under. So they don't like that lower level because it places them under the gun for maybe being not as good a practitioner or non-compliant. So the argument has a lot to do with individualization, provider control over setting goals for a person. How soon do you start treatment and with what and how low do you go? Those questions are actually still probably out there. Just be aware that there's questions like that that exist out there in the world. I am going to work through you with JNC 8, which still is definitionally what a lot of the bigger organizations are using for quality. But be aware, if you work for an individual cardiologist, or even an individual family medicine provider, there may be some people that you want to treat to lower levels for good reason. Those people are people with diabetes, people who have other risk factors for cardiac disease that can come along. So you're going to want to individualize it and be aware that there's varying levels. Okay, that's probably the biggest thing to look at. Okay, so let me just let that be at this point because it will not go away anytime soon. It was interesting to read all the editorials that were written by all the organizations shooting back and forth at each other about what ought to happen in regards to treatment. Let's look at some of the data here, and I'll see a mess up slide here, hypertension. Okay, we're going to have hypertension data. CDC. This information, this was last updated June 16th of 2016, and it's notable that the CDC still uses the JNC8 definition, so all this data they collect about incidents and et cetera comes from the JNC8 definitions. 75 million Americans, 1 in 3 have hypertension. If we go to new guidelines, it'll be close to 1 in 2. 1 in 3 Americans have pre-hypertension, which they define as 120 to 139 over 80 to 89. Only 54% have their hypertension controlled. That's an important element as a primary care provider in the community, is that basically half the people are not at control, even though they have the diagnosis. Many deaths happen from hypertension. That's why it is such a large issue. It causes a lot of deaths. Either directly or is part of a constellation of risk factors that are associated with mortality in people. But 410,000 Americans per year, 1,100 deaths per day, and it costs a lot of money in visits, in medications, and in lost work. That's what they've got. And you know, death, of course, is also priced out by these agencies when they look at what is the cost, you know, of a disease gone bad, you know, with various individuals. So it's an important issue. I gave you a map of prevalence of hypertension just so you would see You see that dark red? The dark red is the greatest prevalence of hypertension, and then it thins out as the colors get lighter. You see we're in the belt that's just full of hypertension. Mostly, okay, we get my little thing. There you go. See? Yeah, it's not working. It's what it is. I know what it is. Don't worry. It's okay. It's two different screens. I'm working off of one that's for me, and y'all are working off of one for you. At the break, I'll change it. But you can see where's one that's stick.
Up here, right here.
Oh. Okay. But y'all can see, you can see where the hypertension is all across the southeast up into West Virginia. Some of this is tied into poverty, and some of it is tied into racial groups. So you've got African American, Native American, those groups have high prevalence. Alaska, okay, we talk about that, you know, it goes to native population, Eskimos, they're at higher prevalence within those populations. So you can see where it is. So Oklahoma's right smack dab in the middle of a lot of diseases of high risk. Okay. Katie didn't move to any more healthy environment necessarily. Okay, it's a job. Okay, look at cardiovascular disease risk. This is a true statement about blood pressure, and important to remember. The relationship between blood pressure and cardiovascular disease is continuous, which means that for every millimeter of mercury higher you go, there's greater risk. It is consistent. It's not like there's 30 people over here, if their pressure is higher, nothing's going to happen to them, and 30 in this group are have something happen. If I take you, individual you, and raise your blood pressure, your risk is up because of that increase in blood pressure. And it is independent of other risk factors, which means you don't have to have hypertension and diabetes. Hypertension all by itself, all things equal, nothing else in your background is a problem. So it's continuous, it's consistent, and it's independent of other risk factors, which makes it a major element that needs to be dealt with in a patient. The higher the blood pressure, the greater is the chance of a number of disorders. Now I think you've already covered some of these things, and you'll be finishing the rest of them out. But the higher the blood pressure, the greater is the chance the person will have a heart attack, a heart failure, stroke, kidney disease, or retinal damage. So you can see that there's an extensive array of problems that can happen, and this kind of illustrates with a little bit more detail. Eyes, you can have retinal damage, you can actually end up blinded, you know, from having hypertension out of control. Brain, stroke, TIAs, and dementia. I know y'all haven't had neurology yet, but I think you've had TIA before. Have y'all had TIA presented? Okay, it's momentary ischemic events in the brain that might create a little symptom, but it passes as soon as the momentary ischemia goes away. It's a sign that you may eventually have a stroke somewhere down the road, but it's an issue. Heart, you have coronary artery disease because of it, heart failure, enlarged heart. Circulation is aneurysm, atherosclerosis is one of the driving factors for atherosclerotic process. In kidneys, you have renal failure. The issue about kidneys is kind of interesting is this. If you have high blood pressure, you're always evaluating for kidney disease because they're linked. But it's also true that kidney disease can actually cause high blood pressure. Very often you don't know what you have. You'll just have a person with high blood pressure and they'll have renal impairment. Which came first, the chicken or the egg? It won't matter because you're going to have to manage both elements. But if you have hypertension with normal kidneys, then it could affect them over time. Professor Reggio knows this from working in the ER. You see, they're almost always sitting there, something's going on, and you really don't quite know how they got to that point, but it's all balled up together, and you have to just address it straight up. What are the benefits of lowering blood pressure? There are some significant benefits, and things that are very positive. Lowering blood pressure substantially reduces risk of a lot of events. Stroke incidence can be reduced by 35 to 40%. That's worth doing. MI reduced by 20 to 25%. That's worth doing. Heart failure reduced by over 50%. One big thing you'll see in a heart failure patient very often, blood pressure is out of control. The first thing you're going to do is unload them by taking their blood pressure down and seeing what you can do beyond that. So those are major issues. 20 to 30% of people who have high blood pressure are unaware that they have it. So a lot of people, there's screening efforts that go on because people need to know it's there. So we've done a better job of identifying this, but not good enough. And as the population gets heavier, we need to be a little bit better about screening because they're usually they can be tied together. Only 40% of those who are aware have controlled blood pressure. Okay, so people know they have high blood pressure, but they're not controlled. And I told you earlier that a good percent of people aren't controlled. So what is the biggest reason why it's not controlled? Either it's inadequately treated, just not enough medications at the right doses or the right combo for that person, or the person does not take things, inadequate drug therapy. And the number one reason people are not controlled is not taking what's been prescribed. And the estimates of that non-adherence, that not taking medication, it can be as high as 70 to 80%. So when you're talking to somebody on a whole string of chronic medications for chronic conditions, and they're not doing well, you have to eliminate the fact that they are taking or not. That's a huge element. And it's kind of hard to get out of some people. Sometimes they'll tell you, I take it just like you prescribe it, but then what they don't say is when they have it, I take it like it's prescribed. When they decide to take it, that might be a week of I'll do it right, then a week of not doing it right. So it's very difficult to get that complete story out, but it is very commonly a problem. Non-adherence. Okay. In your handout, I gave you some comments about accurately measuring blood pressure, and I did not turn all these things into slides yesterday. I might have turned them into slides last night if I had time, but I didn't. Let's just look at, there's just a few key points to think about. And I know y'all have already talked about blood pressure measurement, but I want to talk to you about from the J&C8 perspective, things that can kind of get in the way of it. In usual practice, it's hard to get good measurements because what the guidelines will tell you to do are very likely not going to be possible to do in a busy primary care practice. Okay, let's just look at it. Here's the bullet points on page 5 of your handout. The real recommendation is patients should be seated quietly for at least 5 minutes in a chair rather than on an exam table with feet on the floor and arms supported heart level. How often do you get 5 minutes of quiet before you check the blood pressure? Not often. What usually happens, they get them up out of a chair in the waiting room, bring them back in, and they get triaged in and put into a room. So they're huffing and puffing if they're overweight, and you check the blood pressure then. That'd be the first number. Now the provider very often will check the blood pressure again if the number they see isn't quite what they like. But I'm saying in the way times are set up for primary care providers, oftentimes it's hard to do what the guideline says. But just be aware that also may lead to higher readings than what they have ordinarily under different circumstances. And that's part of the controversy in these guidelines. How are you measured and what are you going to do with that measurement? If huffing and puffing back at a quick blood pressure reading is a little bit elevated and you've got new definitions that lower the level of blood pressure, then you might even treat people with medications in that visit that when they go home in their native state, their blood pressure is lower than that and they're treated based on the higher number, and then they end up lower. So it's kind of a hard conundrum to solve, okay, in the way the world is set up. Look at another one. Measure blood pressure in a standing position is indicated periodically, especially those with risk of postural hypotension. If people talk about being lightheaded and dizzy when they get up out of a chair or off of a bed, you really are obligated to check that. So you need to tilt that person, lay them out, stand them up, check them again, and get a reading. Here's another one, third bullet point. An appropriate size cuff, air bladder, and circulate at least 80% of the arm should be used. Now, y'all been taught these things before, so you have to look at it. So there's the big blood pressure cuffs, and there's the regular blood pressure cuffs. In Oklahoma, you need to have a good supply of big ones, too, because a lot of people are just very overweight, and you'll get an inappropriately high reading if you don't use the right size cuff. Here's this one. Here's the new guidelines, and this just often does not happen. 2 to 3 measurements from at least 2 times during the day should be taken and averaged. And what the new guidelines we're going after is trying to get out of that office blood pressure reading, because people often are nervous when they go into an office. People are checking it out, they're looking at them. I mean, you know yourself, if you'll just think about it, when you sit down and someone's coming to check you, the fact that they're checking you makes you nervous about what they're checking, and your blood pressure can be higher. So there is a white coat hypertension phenomenon.